Hello, my name is Molly Bewald, and I'm a palliative care physician at Mount Sinai Hospital, where I'm also program director of our Hospice and Palliative Medicine Fellowship. And today I'm going to talk about use of methadone to treat pain for patients with serious illness. I have no disclosures. So for any of you who already have some familiarity with this topic, I want to start by pointing out the changes in this area that have happened in the past couple of years. First, some really important new consensus guidelines were published in 2019 in the Journal of Pain and Symptom Management called Safe and Appropriate Use of Methadone in Hospice and Palliative Care, Expert Consensus White Paper by Marilyn McPherson and colleagues. And two of the big practice changes recommended in these new guidelines that I want to point out are a major change in how methadone dose is calculated based on a patient's prior opioid use, and new guidance about EKG monitoring for patients based on their goals of care. So for anybody who's already using methadone to treat pain, these are two important things to keep in mind that I'll highlight during this session. So to start out, what makes methadone so special and different from other opioids that it gets its own whole section of a talk? One really special thing about methadone is that it acts on different kinds of receptors. At the mu opioid receptor, it's an agonist like all of the other opioids. And then it also functions as an NMDA antagonist, similar to how ketamine functions. Because it has these two actions, its effects are really different than other opioids, and the conversion from other opioids to methadone is not linear, which can be really confusing when you're getting used to it. Another very strange and special thing about methadone is that the half-life is enormously variable in different people, between 5 and 130 hours. I don't know of any other medications that have such a wide range in terms of half-life. And this is part of the reason that we treat it so carefully and wait so long between dose increases. If you think about time to steady state, which is somewhere between 5 and 6 half-lives, it means that the range of time to steady state is a really huge range. Another really interesting thing about methadone is that you see it prescribed daily for treatment of opioid use disorder. It works to block cravings for more than 24 hours, but the duration of analgesia is about 8 hours for most patients. So you'll see for pain, we usually prescribe it every 8 hours, although you can prescribe it every 12 or 6, depending on the situation. By the end of this session, I'm hoping that you will feel confident selecting patients to treat with methadone based on their comorbid medical issues and psychosocial concerns, that you feel comfortable calculating a starting dose of methadone based on a patient's prior opioid use, and that you feel comfortable choosing how often to do cardiac monitoring or EKGs based on a patient's prognosis and goals of care. And just briefly, in terms of the topics I'll go through, we'll talk about selecting patients, handling different comorbid conditions, many medication interactions, dosing and conversions, routes of administration, how to handle a patient already on methadone maintenance treatment, and EKG guidelines. Let's start with situations where you might want to choose methadone as a treatment for pain. I'd think about considering it when you see a patient who has some of these characteristics. So someone with moderate, severe, or refractory pain, someone who can't take morphine because they're allergic, methadone's a fine choice, someone with kidney impairment, somebody needing a long-acting opioid, and especially somebody with dysphagia and potentially a PEG, because methadone can be crushed and put through a PEG. It retains its long-acting characteristic in that setting. Somebody with a high opioid tolerance, and potentially patients with neuropathic pain due to NMDA antagonism, although this is a little bit controversial in the field right now, so remain posted on that. What about potentially inappropriate candidates? Things to think about that might make a patient an inappropriate candidate for methadone include someone who's living alone without a caregiver to help them, somebody without a knowledgeable practitioner on transfer who's having multiple transitions in care. When you start methadone, you really want to make sure that the next practitioners caring for your patient will be comfortable continuing to prescribe it. Somebody with QTC prolongation, structural heart disease, or other medical risk factors, and we'll talk more about that in a bit. Sleep apnea, which we'll also talk more about. Someone with a very short prognosis that's less than time to steady state. So someone you expect to die in the coming hours to days might be an inappropriate candidate because it won't be long enough for methadone to really take effect. And someone with a history of opioid non-adherence or substance misuse. And I want to highlight that one because for us to safely prescribe methadone, we really need to be confident that the patient's going to take the pills as prescribed, pick up the phone if you call them and show up to appointments, and not be using other substances you don't know about for safety. Given that by definition in palliative care, the patients that we care for have serious illness, let's start by talking about how to handle comorbidities when prescribing methadone. I want to start with kidney disease. So because methadone is mainly metabolized in the liver and the inactive metabolites are excreted in urine and feces, the kidneys really don't have a major role to play in clearance. This makes methadone a really useful opioid to consider for patients with kidney impairment, including those who are on dialysis. If somebody does have severe kidney disease, it's always a good idea to be cautious with dosing and dose increases. And of note, only 1% of serum methadone is cleared by dialysis. Let's talk about liver disease next. So one important characteristic of methadone is that it has a high bioavailability, meaning that of the methadone you ingest, for most people between 70 and 80% of it will enter the circulation. And it has minimal first pass clearance, meaning that the liver doesn't remove much